Good afternoon, respected teachers. Today, I'm going to present my poster, an unusual case of facial puffiness. Dermatomyositis is one of the major type of inflammatory myopathy with a relative predilection for females and with a characteristic proximal muscle weakness associated with various other cutaneous manifestations. Our patient, a 43-year-old Mrs. X, non-hypertensive, non-diabetic, presented to us with history of facial puffiness for the past 1 month. On the day of her admission, she complained of difficulty in getting up from bed and lifting head from pillow. She gives history of difficulty in getting up from squatting position after passing stool. She also gives history of progressive weakness of both upper and lower limbs, mainly proximal muscle, which is insidious in onset and slowly progressive in nature. She gives history of difficulty in combing the hair and bringing food to her mouth. Her son reported a presence of rash on her cheek. There was no history of decreased urine output, rise in BP, color of urine, swelling of lips, insect bite, diurnal variation of weakness, difficulty in turning head sideways, loss of weight, twitching of muscle, no medicine use apart from diuretic given time to time, no sensory cerebellar and posterior column symptom. General survey was unremarkable except for erythematous lesion over malar region, upper chest, back, and over MCP and PIP joint. Power of bilateral and upper and lower limbs were diminished. Blood for CPK was sent without the use of tourniquet. Proximal muscle weakness was noted on examination and reddish purplish rash around eyelids were noted. EMG, NCD, blood for ANA-HEP2, 25 hydroxyvitamin D, serology and urine RE was sent with other routine investigation. CPK came out to be 990, NCV, generalized myopathic pattern was noted. 25 hydroxyvitamin D was less than 8. Rest of the investigations were within normal limit. Patient was seen by a neurologist and muscle biopsy was advised. And biopsy was done from right vastus lateralis. After biopsy, tap prednisone of 40 mg daily was started and vitamin D was adequately replenished. Coming to the discussion, a diagnosis of dermatomyositis was made as this was a pre-malignant condition. A USG breast was done, which revealed BIDADS 2. USG whole abdomen was done, which was within normal limits, and a PFT was planned after discharge. And patient was taught about the importance of self-breast examination, and stool RE-OBT was also done, which was normal. Coming to the conclusion, dermatomyositis may be difficult to diagnose if extent of disease is limited. It may be associated with infection, autoimmune process, malignancy. It is a rare entity with facial puffiness as one of the early manifestations of the disease. Thank you.